Dear President, thank you for inviting me for this great meeting. Thank you, Professor Al-Amri, Professor Ashraf Armia, for this kind of invitation. Excuse me, I'm going to speak a little bit fast because I have very little time. So, my presentation is about traumatic hyphema. So what is traumatic hyphema? It is blood under the cornea. This is come from the Greek literature. So it's a layer of blood sitting at the bottom of the anterior chamber. The incidence about 15 to 25%. It is more of young age, and it's more males and females, and it increased during warm months due to outdoor activities. So it has economic impact, of course, and what are our concern is the immediate concern, the risk of increased intraocular pressure and the potential for rebleeding. The long-term risk is glaucoma developments, corneal blood staining, optic atrophy from intraocular pressure increase, and permanent vision loss. So what are the mechanisms? Actually, there is a lot of many mechanisms for this. First is blunt trauma. The blunt trauma can be through different mechanisms, coup in the site of impact, or counter coup, or anterior scleral compression, or shock wave propagation. All this will lead to a rupture with small vessel of the iris or ciliary body. What causes the hyphema? What the object? Many objects, usually a projectile which strikes the eye, various objects, rocks, balls, also with the increase of child abuse, the fists and bills. So also the penetrating trauma, it may lead to direct vessel laceration or foreign body injury. There is also a deceleration injury, which is the rapid deceleration of the head, especially in car accidents, or rotational forces which impact the eye, and this will cause also to bleeding from or avulsion of blood vessels. Also, hypotomy may induce rebound. With the initial trauma may cause a temporary hypotomy with re-increase of the blood in the vessel. It may lead to hemorrhage. Also, secondary mechanisms of rebleeding due to the clot resorption or dissolvage, or iatrogenic injury during examination. So what are the diagnostic approaches? Of course, history taking is important. The mechanism, of course, penetrating or blunt. The time since the injury is important. Is associated symptoms, especially systematic or associated injury to the back of the eye. Also, we have to do some imaging studies to see what is going on. Is foreign body or there is or associated fundus hemorrhage. So the clinical presentation is usually visual dispersion, pain and discomfort, and visible blood in the eye. And the grading system is very important because it has a clinical significance in the management of each grade. So severity is from microscopic hyphema, grade 0, up to total hyphema or 8-ball hyphema. This is the pictures from grade 0 to 1, and this is very important to document. So what is the course? Usually the duration of hyphema, it takes like about 1 week. If associated increased intraocular pressure, it takes the same amount, up to 20. The increased intraocular pressure, which is about 22, which is okay to be managed. If we anticipate more than this, if you have near total or total hyphema. Delayed glaucoma due to the development of ghost cell glaucoma, where the erythrocyte lose hemoglobin and the ghost cells circulate forward and obstruct trabecular meshwork. So the most common complication of hyphema is posterior synechiae, peripheral anterior synechiae, of course, corneal blood staining, and later on optic atrophy. So what are the management according to the grade? Either outpatient or hospitalization. Outpatient is microhyphema or grade 1 to 2 hyphema. Of course, hospitalization if we have more grade 3 or 4 or elevated intraocular pressure or both. So what are the management? Bed rest is very important. I have just 1 minute. Strict bed rest, elevation of the head, wearing eye patch to prevent further trauma to the eye, and prevention of continued secondary or hemorrhage. Also, of course, we use corticosteroids and cycloplegic, sometimes antifibrinolytics, either systematic or topical, and of course, if there is glaucoma, we use anti-glaucoma treatment. Indication for surgery if the patient develops uncontrolled glaucoma, corneal blood staining, or persistent large edema. What are the prognosis of visual recovery? Usually, if you have a successful treatment, 70% of the patient will recover vision, 60% of the patient younger than 6 years will have good visual results, 80% and 6% of the, according to the grade, will regain 6-12 vision or more. Bad prognosis associated with posterior segment complication. I would like to take this occasion and opportunity to invite you all to Rio 2025 conference. It will be in 30 to 31 January next year, inshallah. Thank you very much.
Thank you. Thank you, Dr. Mustafa.